Welcome. My name is Dr. Dawn Shepard, and today we will be discussing brief psychotherapy techniques in primary care. This presentation focuses on practical, evidence-based approaches that can be integrated into real-world clinical encounters, even within the time constraints of a typical visit. The goal is to move beyond theory and help you develop skills you can immediately apply in practice. 1 in 5 adults in the United States experiences a mental health condition, and approximately 50% of mental health care is already delivered in primary care settings. This means primary care is not just a referral point, it is a frontline mental health environment. At the same time, the average primary care provider has about 7 minutes to address a mental health concern, which creates a significant challenge in delivering meaningful, effective care. Despite these time constraints, outcomes improve significantly, up to 4 times better, when brief, structured psychotherapy approaches are incorporated into care. These are not lengthy traditional therapy sessions, but focused, evidence-based interventions that can be delivered within routine visits. About 70% of patients prefer to receive mental health care in primary care, where care is more accessible, less stigmatized, and better integrated with their overall health. Taken together, this data highlights a clear clinical opportunity. By integrating brief psychotherapy skills into standard visits, providers can close gaps in access, improve both mental and physical health outcomes, and strengthen the therapeutic relationship without requiring additional time or providing help to patients while they wait for that specialty referral if needed. Brief psychotherapy is a structured, time-limited, and goal-directed therapeutic approach, typically delivered over 4 to 20 sessions, with a clear focus on achieving specific, measurable outcomes. It is grounded in evidence-based practices supported by decades of research, including randomized controlled trials demonstrating effectiveness across a range of mental health conditions. This approach is inherently patient-centered, with goals developed collaboratively to align with the patient's values, preferences, and readiness for change. Brief psychotherapy is designed to be adaptable to primary care, allowing the nurse practitioner to embed focused interventions into routine visits while managing chronic disease rather than requiring separate traditional therapy sessions. The emphasis is on maintaining structure, promoting efficiency, and facilitating meaningful progress within a limited time frame. We will now shift to motivational interviewing, a brief, evidence-based approach designed to help patients resolve ambivalence and strengthen their own motivation for change. This approach is particularly useful in primary care, where many patients are not resistant, but rather uncertain or conflicted about behavior change. Motivational interviewing provides a structured way to engage patients, explore their ambivalence, and guide them toward making meaningful, self-directed changes. Motivational interviewing is a collaborative, goal-oriented communication style used to strengthen a patient's intrinsic motivation for change by eliciting their own reasons within an atmosphere of acceptance and compassion. A central concept in this approach is ambivalence, which refers to the simultaneous presence of competing motivations, meaning wanting to change and wanting to stay the same at the same time. This is a normal and expected part of behavior change, not resistance or noncompliance. The clinician's role is to help patients explore that ambivalence and gradually resolve it in favor of change. This approach is grounded in the spirit of motivational interviewing through collaboration instead of authority, acceptance without judgment, compassion for the patient's well-being, and evocation of the patient's own values and goals. In primary care, this is especially relevant in areas such as substance use, medication adherence, and lifestyle-related conditions, where patients often feel conflicted. The shift is from directing change to facilitating it, allowing the patient to become the primary voice for change. Motivational interviewing follows a structured 4-process sequence that guides the clinical interaction. The first is engaging, which focuses on building rapport and establishing a therapeutic alliance. This is where the nurse practitioner avoids common traps such as overassessing, prematurely giving advice, or labeling the patient. The second process is focusing, where the nurse practitioner and patient collaboratively identify a specific target for change, often using agenda setting when multiple concerns are present. The third process is evoking, which is the core of motivational interviewing. Here, the nurse practitioner elicits change talk by helping the patient articulate their own reasons, desires, and motivations for change while responding skillfully to sustained talk without confrontation. The final process is planning, where the conversation shifts toward commitment and action, and the patient begins to develop a concrete, self-directed plan, including identifying potential barriers and supports. These processes are not strictly linear, and the nurse practitioner may move back and forth between them depending on the patient's readiness and response. Motivational interviewing is operationalized through core communication skills known as OARs, meaning open-ended questions, affirmations, reflective listening, and summarizing. These are intentional strategies used by the nurse practitioner to guide the conversation toward change. Open-ended questions invite elaboration rather than yes or no responses, allowing the patient to explore their thoughts more fully. Affirmations are used to recognize strengths, efforts, and values, helping to build self-efficacy. For example, "You've been trying to manage this despite a lot of stress, and that says a lot about your commitment." Reflective listening is the most essential skill, as it demonstrates understanding while also shaping the direction of the conversation, and summarizing helps organize and reinforce what the patient has said. These skills are used to elicit and strengthen change talk, which is the patient's own language in favor of change. This is organized into DARNCAT, which stands for desire, ability, reasons, and need. This represents preparatory language, while commitment, activation, and taking steps reflect movement toward action. For example, a patient might say, "I know I need to cut back on drinking, and I think I could do it if I had more support," which reflects both need and ability. The clinical task is to recognize, reinforce, and strategically respond to this type of language, as it is one of the strongest predictors of actual behavior change. Motivational interviewing becomes clinically useful when applied to real conversations, particularly in managing ambivalence. One core tool is decisional balance, where the nurse practitioner helps the patient explore both sides of the behavior, what they value about staying the same and what they might gain from change. This might sound like, "What do you enjoy about drinking and what concerns you about it?" followed by, "Where does that leave you?" It is also important to differentiate sustained talk from discord. Sustained talk reflects the patient's own arguments against change and should be met with reflective listening, such as, "Part of you feels this isn't a problem right now," whereas discord signals strain in the relationship and requires the nurse practitioner to step back and re-engage. In these moments, affirmations can be used to de-escalate. For example, "It sounds like you've been dealing with a lot of pressure about this, and you've been trying to handle it in your own way." Another key strategy is the use of importance and confidence rulers, asking, "On a scale of 0 to 10, how important is it for you to make this change?" followed by, "Why a 6 or whatever they say and not a 2 or some other lower number?" to elicit change talk. Confidence can be explored with questions like, "What would help move you from a 5 to a 7 to make you feel more confident about making this change?" These approaches allow the nurse practitioner to guide the conversation while maintaining collaboration and keeping the patient as the primary voice for change. We will now shift to cognitive behavioral therapy, or CBT, which is a structured, evidence-based approach focused on identifying and modifying patterns of thinking and behavior that contribute to emotional distress. In contrast to motivational interviewing, which focuses on building readiness for change, CBT provides a framework for actively changing thoughts and behaviors once the patient is engaged and motivated. This approach is widely used in primary care and is particularly effective for conditions such as depression, anxiety, insomnia, and chronic illness management. The cognitive model in CBT describes how a situation triggers automatic thoughts, which then influence emotional, physiological, and behavioral responses. The key point is that patients are not reacting directly to the situation itself, but to their interpretation of that situation. These automatic thoughts are often rapid, habitual, and not fully examined, yet they drive how the patient feels and responds. For example, a patient whose self-talk makes them think, "I'm a failure." They may experience sadness, low energy, and withdraw from activities, reinforcing the cycle of depression. Over time, these patterns are shaped by deeper core beliefs, which often fall into themes such as helplessness, unlovability, or worthlessness. The role of the nurse practitioner is to help the patient identify these automatic thoughts, examine their accuracy, and begin to develop more balanced and adaptive ways of thinking, which in turn can shift emotional and behavioral outcomes. CBT is applied through a set of structured techniques that help patients identify, evaluate, and modify unhelpful thinking and behavior patterns. Cognitive restructuring is central, where the nurse practitioner helps the patient identify automatic thoughts, examine the evidence for and against them, and generate more balanced alternatives. For example, a patient who says, "I always mess things up," may be guided to consider what evidence supports that and what evidence does not. Thought records extend this process by having patients document situations, thoughts, emotions, and alternative responses, such as writing down, "I didn't get the job," the thought, "I'm not good enough," and then developing a more balanced response. Behavioral activation is particularly important in depression, where the focus is on increasing engagement in meaningful activities. For example, scheduling a short walk or calling a friend, even when motivation is low. Behavioral experiments are used to test beliefs in real-world settings, such as a patient who believes, "If I speak up, people will judge me," agreeing to share one comment in a meeting and then evaluating the outcome. Another practical CBT tool is the use of coping cards, which are brief, portable reminders that help patients respond to automatic negative thoughts in real time. A coping card typically includes a common distressing thought on one side and a more balanced, evidence-based response on the other, developed collaboratively with the patient. The goal is to make adaptive thinking accessible at the moment it is needed, especially when emotional intensity makes it difficult to generate alternative thoughts independently. For example, a patient who frequently thinks, "I'm going to fail," might develop a coping card that includes a response such as, "I've prepared for this, and I've handled similar situations before." Psychoeducation supports all of these techniques by helping patients understand the cognitive model, with the goal of making the patient their own therapist over time. CBT follows a structured session format that helps maintain focus and maximize efficiency, which is especially important in primary care. A typical session begins with a brief mood evaluation, often using a symptom scale or quick check-in, followed by a bridge from the previous visit to assess progress. The nurse practitioner then reviews the prior action plan or homework, reinforces effort, and identifies any barriers. The session is guided by a collaboratively set agenda to prioritize the most relevant concerns, after which a specific cognitive or behavioral skill is introduced and applied to the patient's current situation. The session concludes with a new achievable action plan and a brief summary to reinforce key points and ensure understanding. Clinically, CBT is highly effective across a range of conditions. In depression, the focus is often on behavioral activation and problem-solving to counter withdrawal. In generalized anxiety, the nurse practitioner works on identifying and challenging catastrophic thinking patterns. In panic disorder, interoceptive exposure helps patients reinterpret physical symptoms. In social anxiety, exposure strategies and reduction of safety behaviors are emphasized. In chronic pain and insomnia, CBT focuses on behavioral interventions such as activity pacing and sleep restructuring to improve function. In PTSD, trauma-focused CBT approaches are used to help patients process and reframe trauma-related thoughts and reduce avoidance. The structured nature of CBT allows the nurse practitioner to apply targeted interventions efficiently while helping patients build skills they can continue using independently. We will now shift to interpersonal therapy, or IPT, which focuses on the relationship between mood and interpersonal functioning. IPT is based on the understanding that psychological symptoms often occur within a social and relational context, and that improving communication and relationships can reduce distress. In primary care, this approach is particularly useful when symptoms are linked to life events such as loss, role changes, or interpersonal conflict, allowing the nurse practitioner to target the relational factors contributing to the patient's presentation. Interpersonal therapy is grounded in a biopsychosocial model. recognizing that psychological distress emerges from the interaction between biological vulnerability and interpersonal stress within a broader cultural and social context. In IPT, symptoms are not viewed in isolation, but as occurring in response to disruptions in relationships, social roles, or support systems. This includes factors such as acute interpersonal crises, inadequate or disrupted social support, and underlying vulnerabilities that increase sensitivity to stress. The model emphasizes a stress diathesis framework, where interpersonal stressors activate or exacerbate symptoms in individuals who may already be biologically or psychologically vulnerable. A key distinction in IPT is that the focus is on the present rather than the past, and on current functioning rather than personality structure. The nurse practitioner works to identify how recent or ongoing interpersonal events are contributing to the patient's symptoms and uses that formulation to guide treatment. This often involves helping the patient make connections between mood changes and relationship patterns, such as increased depression following a role transition or unresolved conflict. IPT is also structured and time-limited, typically focusing on one primary interpersonal problem area, which allows for targeted, efficient intervention. The overall goal is to reduce symptoms by improving communication, strengthening social support, and helping the patient navigate interpersonal stress more effectively. For example, a patient presenting with new onset depression after a divorce may initially describe symptoms of low mood, poor sleep, and loss of interest. Using an IPT framework, the nurse practitioner helps the patient link these symptoms to the interpersonal stressor of role transition from partner to single individual and explores how changes in identity, support systems, and daily routines are contributing to distress. Treatment then focuses on helping the patient process the loss, adjust to the new role, and rebuild social support rather than focusing solely on symptom reduction with medication. IPT focuses on specific interpersonal problem areas that are most closely linked to the onset or maintenance of symptoms. In this model, 3 primary areas are emphasized. The first is grief and loss, which involves difficulty processing the loss of a significant person, where the nurse practitioner helps the patient work through the loss and re-engage in life. The second is role transitions, which occur when an individual is adapting to a major life change, such as divorce, illness, or changes in family roles. Here, the focus is on helping the patient adjust to a new identity and expectations. The third is interpersonal conflict, which involves ongoing difficulties or disagreements with significant others, where the goal is to improve communication, clarify expectations, and work toward resolution or acceptance. Within each of these areas, the nurse practitioner also assesses how the patient is responding interpersonally, such as patterns of withdrawal, limited social support, or difficulty expressing needs, which may be contributing to the persistence of symptoms. These responses are not treated as separate problem areas, but as important factors that shape how the patient experiences and navigates the interpersonal stressor. In practice, the nurse practitioner identifies which problem area is most closely connected to the patient's symptoms and maintains that focus throughout treatment. For example, a patient presenting with depression after a recent move and job change may be conceptualized within a role transition, with attention to both the change itself and the patient's response, such as social isolation or difficulty building new support systems. IPT is a structured, time-limited approach that typically progresses through 3 phases. An initial phase focused on assessment and formulation, a middle phase focused on active intervention, and a termination phase that consolidates gains and prepares the patient for independence. In the initial phase, the nurse practitioner conducts an interpersonal inventory, assessing current and past relationships, patterns of communication, and available social supports. This process helps identify the primary interpersonal problem area, such as grief, role transition, or conflict, and establishes a clear treatment focus. In the middle phase, the work becomes more active and targeted. The nurse practitioner helps the patient make connections between mood symptoms and interpersonal events, while introducing techniques to improve functioning within the identified problem area. This may include communication analysis, where the patient and nurse practitioner examine specific interactions in detail, role-playing to practice more effective communication, and encouragement of affect, helping the patient identify and express emotions more directly. The goal is to improve interpersonal effectiveness and strengthen support systems. In the termination phase, the focus shifts to reinforcing progress, reviewing skills learned, and preparing the patient for future interpersonal challenges. For example, a patient working on interpersonal conflict may practice assertive communication through role play, then apply it in a real interaction and reflect on the outcome. This structured approach allows IPT to remain focused, efficient, and directly applicable within primary care while addressing the interpersonal drivers of distress. In some cases, particularly with recurrent conditions such as depression, IPT may transition into a maintenance phase with less frequent visits to support relapse prevention and sustain interpersonal gains over time. We will now shift to supportive therapy, which focuses on stabilization, emotional support, and strengthening coping in the context of current stressors. Unlike more structured approaches such as CBT or IPT, supportive therapy is less directive and more flexible, allowing the nurse practitioner to meet the patient where they are, particularly in situations involving acute distress, chronic illness, or limited psychological resources. The emphasis is on maintaining the therapeutic relationship, reducing distress, and supporting adaptive functioning. Supportive therapy is a flexible, patient-centered approach focused on stabilization, emotional support, and strengthening coping in the context of current stressors. In primary care, it is often used when patients are experiencing acute distress, chronic illness, or limited capacity for more structured therapies, and it is guided by several core elements. First, emotional validation involves acknowledging the patient's experience in a way that reduces distress and builds trust. For example, given everything you're dealing with, it makes sense that you feel overwhelmed. Second, active listening requires the nurse practitioner to fully attend to the patient and reflect understanding, such as, "It sounds like this has been building for a while." Third, encouraging focuses on reinforcing effort and engagement. For example, "The fact that you came in today and are talking about this is an important step." Fourth, strengthening coping involves identifying and reinforcing strategies the patient is already using, such as, "What has helped you get through difficult days like this before?" Fifth, psychoeducation provides information to help the patient better understand their symptoms, for example, explaining how stress can impact sleep, mood, and physical health. Finally, problem-solving support helps the patient identify manageable next steps, such as, "What feels like one small thing you could try this week?" Mental health symptoms do not occur in isolation. They are often shaped by the patient's family context, including patterns of interaction, roles, and shared stressors. Family dynamics can contribute to the development or maintenance of symptoms through conflict, caregiving demands, intergenerational patterns, and substance use within the system. The nurse practitioner should assess not only the individual, but also how the family environment may be supporting or exacerbating distress. This includes recognizing patterns such as overfunctioning and underfunctioning roles, emotional reactivity, and communication styles that influence how symptoms are expressed and maintained. Supportive techniques can be applied within this context to help stabilize the patient and improve functioning. Reassurance may be used to reduce acute distress. For example, "You're not alone in this, and we can work through it together." Normalizing helps reduce shame, such as, "Many people in similar situations feel this way." Reinforcing strengths highlights resilience. For example, "You've continued to show up for your family despite these challenges." Reframing offers a different perspective, such as helping a patient see a family member's behavior as concern rather than criticism. Graded task assignment breaks overwhelming situations into manageable steps. For example, identifying one small change in communication or routine within the family system. In primary care, this approach is often brief and focused, but still impactful. Even a few targeted questions about relationships, support, and stressors can provide important context for treatment. By integrating supportive techniques with an awareness of family dynamics, the nurse practitioner can improve engagement, tailor interventions, and support more sustainable outcomes within the patient's real-life environment. Remember, avoid excessive reassurance as it can unintentionally reinforce dependence and cause more anxiety. You want to provide support while encouraging the patient's own coping and problem-solving abilities. Psychotherapy and medication target different but complementary aspects of mental health conditions, and combining them often leads to improved outcomes. Medications primarily address biological symptoms such as mood, anxiety, sleep, and neurovegetative changes, while psychotherapy targets cognitive patterns, behaviors, and interpersonal functioning that contribute to the persistence of symptoms. Symptom reduction alone does not change the underlying patterns that drive relapse, which is why combining these approaches is often more effective than either alone. In clinical practice, combined treatment is typically considered in moderate to severe conditions, recurrent disorders, significant functional impairment, or when there is only a partial response to psychotherapy or medication alone. For example, a patient with major depression may benefit from medication to improve energy and concentration, allowing greater engagement in CBT, while CBT addresses negative thinking patterns and reduces relapse risk. Similarly, in anxiety disorders, medication may reduce physiological arousal, while psychotherapy targets avoidance and cognitive distortions. A helpful framework for decision-making is the clinical triad. Consider and document the patient's symptom severity, functional impairment, and patient preference. These factors guide whether to initiate psychotherapy, medication, or both. When prescribing, key principles include starting low and titrating gradually, selecting medications based on the patient's symptom profile and comorbidities, monitoring for response and side effects, and regularly reassessing effectiveness. You do not want to prescribe a psych medication and provide extended refills without follow-up. Ongoing reassessment is essential to evaluate response, adjust dosing, and determine when referral or additional intervention is needed. This table summarizes how to select an appropriate brief psychotherapy approach based on the patient's presentation, primary target, and expected course of treatment. Motivational interviewing is most useful when ambivalence is present, such as with substance use or non-adherence, and the primary target is motivation for change, often delivered over brief or ongoing encounters. Cognitive behavioral therapy is best suited for conditions such as depression and anxiety, where the focus is on modifying maladaptive thoughts and behaviors, typically over 6 to 12 sessions. Interpersonal therapy is indicated when symptoms are closely linked to relationship stressors, such as grief, role transitions, or interpersonal conflict, with a similar short-term structured course. Supportive therapy is appropriate for patients experiencing acute distress, chronic illness, or limited psychological resources, with the primary goal of stabilization and support, and may be used over a variable duration depending on need. Also included are key tools from solution-focused therapy, which emphasize efficiency and strengths-based change. These include the miracle question, which helps the patient envision a preferred future, scaling questions which assess current functioning and track progress over time, and identifying exceptions where the nurse practitioner helps the patient recognize times when the problem is less severe or absent. These tools are particularly useful in primary care because they promote rapid engagement, build on existing strengths, and help patients identify achievable, solution-oriented steps within a limited time frame. Understanding family context is essential in mental health, as patterns of relationships, roles, and intergenerational influences often shape how symptoms develop and are maintained. A genogram is a practical tool that allows the nurse practitioner to visually map family structure and identify patterns across generations, including mental health conditions, substance use, relationship dynamics, and sources of support or conflict. In practice, the genogram helps move beyond individual symptoms to a broader systems perspective. For example, it may reveal patterns such as repeated substance use across generations, caregiver burden within the family, or strained relationships that contribute to ongoing stress. This information can guide more targeted interventions, such as addressing communication patterns, identifying support systems, or recognizing areas of vulnerability. In primary care, the use of a genogram is often brief and focused rather than comprehensive. Even a simplified version, asking about key relationships, family mental health history, and sources of support, can provide valuable insight. The goal is to enhance clinical understanding and inform care by recognizing the patient within their broader relational system. We've spent the last 30 minutes building your clinical toolkit with motivational interviewing, CBT, IPT, and supportive therapy. You now have real skills for doing this work. But there's a piece that doesn't get taught in most programs, and it costs providers and their patients. That's billing. Specifically, how do you translate what you just did in that room into a CPT code that gets reimbursed, stays compliant, and actually reflects the care you delivered? Everything in this segment is grounded in the Medicare local coverage article governing psychiatry and psychology services. It was revised January 1st, 2026, so this is current today and may change tomorrow, so please verify it when you start practicing. There are over 25 CPT and HCPCS codes covered under this article, and over 800 ICD-10 diagnoses that support medical necessity. You don't need to memorize, but remember to check your state's scope of practice. Who can build these codes? Before we touch a single psych code, we have to talk about scope. This is the foundational compliance question, and one that NPs in particular often haven't been explicitly taught. The rule is this: psychiatric CPT codes may be used by physicians and non-physicians, including nurse practitioners, when the services performed are within the scope of their state license and their clinical practice and education. Both criteria must be met, not one, but both. For FNPs in primary care, this means you can bill psychiatric codes for depression and anxiety management, ADHD, insomnia, and conditions you are trained to manage. Medication management for psychiatric conditions flows through your E and M codes, which we'll talk about. E and M stands for evaluation and management. If you're conducting a brief structured behavioral intervention during a visit, that may qualify for a psychiatric CPT code, as long as it's within your training and included in your NP protocol. What you cannot do is bill codes that require PMHNP level training if that training isn't in your background. For example, if you haven't been trained in structured psychotherapy, billing a standalone psychotherapy code creates exposure. For PMHNPs, the scope is broader. You have the full range of psychiatric codes within your state license. And critically, 90792, the Psychiatric Diagnostic Evaluation with Medical Services. This is your initial evaluation code when prescribing psych meds. 90791 is the code for the initial psych evaluation without prescribing meds. We'll come back to this distinction. One more thing for PMHNPs specifically. Your authority to provide psychotherapy varies by state. Some states explicitly authorize it, others are silent or restrictive. Florida is permissive, but that does not automatically extend to other states if you're practicing via telehealth across state lines. Always consult your state board before assuming. The warning bar at the bottom of this slide is not a formality. Billing outside your scope is a compliance risk. It can trigger audits, recoupment, and in serious cases has licensing consequences. When in doubt, verify. Now here's where most billing education goes wrong. It starts with a list of codes. We're not doing that. We're starting with the logic because once you understand the 5 categories, the codes place themselves. Category 1, diagnostic evaluation. These are your 90791 and 90792 codes. This is where you start with a new patient, or restart after a significant break or change in status. Category 2, individual psychotherapy. Codes 90832, 90834, and 90837. These are standalone psychotherapy codes, time-based, used when the focus of the visit is the therapy itself, with no E and M component. Category 3, E and M plus psychotherapy. This is the add-on category, 90833, 90836, and 90838. These are used when you do both a medical evaluation and a psychotherapy session in the same visit. They are add-ons to an E and M code, not standalone codes. Category 4, crisis psychotherapy, 90839 and 90840. These stand together, meaning they cannot be combined with regular psychotherapy codes on the same date, and that's a rule many get wrong in practice and it gets kicked back. Category 5, interactive complexity, code 90785, This is an add-on, never billed alone, for specific communication difficulties during a psychiatric procedure, particularly relevant in primary care. Notice what's happening here. Each category answers a different clinical question. Was this a first visit? Category 1. Was the whole visit therapy? Category 2. Did I do both medicine and therapy? Category 3. Was this a crisis? Category 4. Was there a communication complicating factor? Category 5. That's the map. Let's go deeper on each one. Before we move into the psychotherapy codes, we need to stop here because this is the first billing decision a PMHNP makes with every new patient, and it is one of the most commonly miscoded services in psychiatric practice. There are 2 codes for the psychiatric diagnostic evaluation, 90791 and 90792. They look almost identical. The difference is 3 words. 90792 says with medical services. As a PMHNP in a treatment role, 90792 is your code. This is your default for every initial psychiatric evaluation. Here is what with medical services actually means in practice. Prescribing authority is exercised, or medication decision-making occurs, even if you defer starting the medication that day. You assessed medical factors relevant to psychiatric treatment, current medications, contraindications, cardiac history, renal and hepatic function where relevant, substance use. You ordered or planned labs relevant to medication management. Now here's the question I get. What if I did the evaluation but I didn't prescribe? Maybe you wanted labs back first. Maybe the patient needed more time to decide, or you are waiting on a court order. Maybe you determined at the end of the visit that medication wasn't the right first step. The answer is 90792 still applies, as long as medical decision-making occurred. Document your medication considerations, document your clinical reasoning about why you're deferring, document the medical factors you assessed. That narrative is what justifies 90792 on review. Now, that said, there are circumstances where a PMHNP would appropriately bill 90791. And that's when you are functioning in a purely evaluative role where prescribing is explicitly not part of the engagement. Forensic evaluation, you've been retained to assess competency, criminal responsibility, or fitness for duty. You are not the treating provider, you are not prescribing. School-based assessment, conducting a diagnostic evaluation where the scope is limited to diagnosis and educational recommendations, no prescribing authority exercised. An independent medical examination retained by an employer or insurer, a disability evaluation for SSA or the VA. In all of these, the common thread is no treatment relationship, no prescribing authority exercised, evaluation is the entire scope. That is 90791 territory, but that is not what you typically do. In standard clinical practice as a treating PMHNP with prescriptive authority, 90792 is your code. One more thing, 90792 is used once at the onset of treatment. It is not an annual code. After the initial evaluation, your ongoing visits move into the psychotherapy or E&M code set. The LCD gives you 4 specific circumstances where you can repeat it. A break in treatment of approximately 6 months, admission to inpatient psychiatric status, a significant acute change in mental status, or a need for a second opinion or diagnostic clarification. Outside of those 4, you cannot rebill a diagnostic evaluation for an established patient you have been seeing continuously. The standalone psychotherapy codes are time-based, and the time thresholds matter. 90832 is your 30-minute code, but the actual face-to-face time window is 16 to 37 minutes. 90834 is your 45-minute code, covering 38 to 52 minutes of face-to-face time. And 90837 is your 60-minute code, 53 minutes or more. 2 words in that last sentence are doing a lot of work. Face-to-face. The time that counts toward these codes is time spent directly with the patient. Not documentation time, not coordination time, not the 5 minutes you spent reviewing the chart before walking in. Face-to-face time only. Use these codes when the focus of the visit is individual psychotherapy. If you briefly discuss a patient's anxiety during a diabetes visit and prescribe a medication, that is not a psychotherapy visit. If you conduct a structured 45-minute CBT session for generalized anxiety disorder, that is. The documentation requirement is straightforward but critical. You must document the time spent face-to-face and the medical necessity for the service. Not assumed, documented. One more rule: if a session runs longer than 90 minutes, reimbursement requires documented medical necessity for the extended time. That's not a common situation in primary care, but it's worth knowing. This slide is the one that trips up the most providers, including experienced ones. Let's slow down here. You can bill a medical evaluation and a psychotherapy session on the same date of service. That's legitimate, it's billable, and for PMHNPs especially, it reflects what actually happens in a med management plus therapy visit. The key is how you do it. The add-on codes are 90833, 90836, and 90838. Each represents 30, 45, or 60 minutes of psychotherapy added to an E and M code. Here's the critical rule, and I want you to say it back to yourself. The time you spend on E and M activities cannot count toward the psychotherapy time. They are two separate, identifiable services, separate documentation, separate medical necessity. The time cannot overlap. What does that look like in practice? You review labs, adjust medications, update the problem list. That's your E and M. You then conduct a structured 35-minute depression-focused therapy session. That's your psychotherapy. Two distinct services, documented distinctly. Now, the common errors. First, do not use time as the basis for E and M code selection when you're also billing a psychotherapy add-on. Your E and M level is determined by medical decision-making, not by total visit time. Second, prolonged service codes may not be reported alongside the psychotherapy add-on codes. Third, both services must be significant and separately identifiable. You cannot do 5 minutes of medication review and call it an E and M. That won't hold up to scrutiny or audit. One reassurance, though, is that a separate diagnosis is not required. You can have the same ICD-10 code driving both the E and M and the psychotherapy, as long as both services are documented as distinct. And psychotherapy codes are payable in all settings: inpatient, outpatient, office, or telehealth. The site of service is not a barrier. Let's bring this to life with 3 scenarios that represent what actually happens in primary care. Scenario A, E and M only. Your patient comes in with hypertension. You notice she seems stressed. You ask briefly about anxiety, prescribe lisinopril, and suggest she reduce stress. You bill the E and M code only. Why? Because the mental health piece was incidental. It wasn't the focus of a structured, documented intervention. You didn't conduct psychotherapy. You noticed and responded, but that response was part of your E and M counseling, not a separate psychiatric service. Scenario B, E and M plus psychotherapy. Your patient has type 2 diabetes and major depressive disorder. In the same visit, you address her glucose management, reviewing labs, adjusting metformin, updating her problem list. That's your E and M. You then conduct a structured 30-minute CBT-based behavioral intervention for her depression, which you document separately with its own clinical narrative. That's 90833 as the add-on. This is appropriate, this is billable, and this is what integrated care actually looks like when documented correctly. Scenario C, psychotherapy only, established patient. The entire 45-minute visit is focused on generalized anxiety disorder using motivational interviewing and CBT techniques. No new medical issues, no medication adjustments. You bill 90834 alone. The question you should ask yourself at every visit is this: is the mental health intervention the focus of a structured, documented service, or is it incidental to the medical visit? That question determines your code selection. Interactive complexity is an add-on code, 90785, that many providers either don't know about or avoid because they're uncertain when it applies. In primary care, it applies more often than you'd think. Here's the core definition from the Local Coverage Determination, LCD. It's for specific communication difficulties during a psychiatric procedure, and 3 categories of patients typically qualify. First, minors or adults with legal guardians. If you're providing a psychiatric service to a child or to an adult whose guardian is present and participating, you have a qualifier. Second, adults who request others to be involved. If an adult patient brings a family member or requests an interpreter to participate in the visit, not just translate in the waiting room, but actively participate, that qualifies. Third, patients involved with third parties, child welfare agencies, probation officers, schools. If those systems are involved and relevant to the visit, that's your qualifier. But qualifying patient population is only half the equation. You also need documentation of at least one specific communication difficulty. The LCD gives you 4 to choose from: maladaptive communication, high anxiety, repeated questions, disagreement, that complicates delivering care, caregiver emotions or behavior that interfere with the treatment plan, disclosure of a sentinel event, abuse, neglect, where you've initiated a mandated report and begun discussing it with the patient and others in the visit, or use of an interpreter, translator, or play equipment to overcome significant language barriers. The last one is particularly relevant in South Florida primary care settings where language access is a daily reality. If you have a patient with limited English proficiency, a participating interpreter, and you're conducting a psychiatric service, that's 90785. Okay, now the hard stops. You cannot add 90785 to crisis codes 90839 or 90840, and you cannot add it to an E&M code when no psychotherapy is also being reported that day. It must attach to a qualifying psychiatric service. Crisis codes stand alone. That's the most important thing to remember about 90839 and 90840, and it's the rule that gets violated most often. 90839 covers the first 60 minutes of psychotherapy for crisis, reported by itself, covering the initial intervention. 90840 is the add-on for each additional 30 minutes beyond that, used with 90839 only when the crisis intervention requires extended time. You will encounter crisis situations in primary care. A patient discloses active suicidal ideation during what you thought was a routine follow-up. A patient arrives in acute psychiatric distress. These situations happen, and when they do, you need to know your billing options in advance, not in the middle of managing the crisis. The rules are absolute. Do not combine 90839 or 90840 with regular psychotherapy codes on the same date. Do not combine them with 90791, 90792, or 90785 on the same date because these codes stand alone. There's an update effective January 1st, 2024 that you need to know. HCPCS codes G0017 and G0018 are now used instead of 90839 and 90840 for non-facility, non-office places of service. So if you're delivering crisis psychotherapy in a patient's home or via a community-based program that is not a facility and not your office, you use the G codes. If you're in the office or an applicable facility setting, hospital, ED, you continue with 90839 and 90840. For documentation, you need to capture the precipitating event, the patient's mental status at the time, the specific intervention you provided, the time spent, and the medical necessity for crisis-level care, as distinct from routine psychotherapy. That clinical narrative is what protects you. Let's put all of this together. Let's read through the scenario. Maria is a 42-year-old established patient with type 2 diabetes and a recent diagnosis of MDD. She presents today with her teenage daughter, who is serving as interpreter. Maria has limited English proficiency. You spend 20 minutes addressing glucose management and adjusting metformin. You then spend an additional 35 minutes conducting structured CBT-based therapy focused on her depression and functional impairment. The daughter's presence is necessary for communication and creates some complexity in managing the session. What do you bill? Look at the options. Option A, 90837 alone, would mean you're billing a standalone 60-minute psychotherapy code, but the 20-minute E&M component was real and distinct. You can't ignore it, and you also can't fold it into the therapy time. So A is wrong. Option B, E&M plus 90836, would mean billing the 45-minute psychotherapy add-on. But the psychotherapy time was 35 minutes, which falls in the 30-minute code range. That maps to 90833, not 90836. So B overcounts the therapy time. This is wrong. Let's look at option D. 90839 is the crisis code. Maria is not in crisis. She's distressed, she has MDD, but distress does not equal crisis. This is a common misconception. Crisis codes require crisis-level clinical presentation. So this one is wrong too. Option C is correct. E and M for the glucose management and metformin adjustment, plus 90833, the 30-minute psychotherapy add-on, because 35 minutes of face-to-face psychotherapy maps to the 30-minute code, plus 90785, interactive complexity, because the daughter is serving as interpreter and is actively participating in the psychiatric service, which is exactly what the LCD describes as a qualifying communication factor. The times don't overlap. The services are separately identifiable. The documentation supports each component. That's a clean, defensible claim. 6 things I want you to leave with. 1. Scope first. Every time, before you select a code, ask yourself, is this service within my state license and within my clinical education? You need to meet both criteria, not one. When in doubt, your State Board of Nursing is your resource. 2. 90791 versus 90792. If you're a PMHNP and you're doing an initial psychiatric evaluation that includes medical services, prescribing, medical decision-making, you bill 90792. We've discussed when to use 90791. 3. E and M and psychotherapy on the same day is legitimate and billable, but the time cannot overlap, and both services must be documented separately with independent medical necessity. This is not a technicality. It is the structural requirement for the claim to hold. 4. Interactive complexity is an add-on you're probably underusing. In primary care especially, with minors, with limited English proficiency patients, with families involved in care, 90785 often applies. Document the specific communication difficulty, not just the qualifying patient category. 5. Crisis codes stand alone from the regular psychotherapy code set. 90839 and 90840 go together as a pair. 90839 opens the crisis intervention, and 90840 is added for each additional 30 minutes beyond that first hour when clinically necessary. What they cannot do is mix with the routine psychotherapy codes. So within the crisis code family, 90839 and 90840 work together. Outside that family, they stand alone. 6. And this is the one that ties everything together. Documentation is the difference between a clean claim and an audit. The code you select must be supported by what is written in the chart. For psychotherapy, document time, medical necessity, the nature of the service. These must be in the record, not assumed, not implied. If it's not documented for billing purposes, it didn't happen. I hope this lecture is helpful. As you move forward in your practice, remember that our role is not just to diagnose and prescribe, but to engage, understand, and guide patients through change. The most impactful moments in care are often not the medications we choose, but the conversations we have, how we ask, how we listen, and how we help patients make meaning of their experiences. Use these approaches not as rigid frameworks, but as tools to think more clearly, respond more intentionally, and meet patients where they are. Ask questions that uncover meaning, not just symptoms, and trust that even brief, thoughtful interactions can make a lasting difference.